Dr. Mathew Kurian to talk on managing severe IFIS without panicking. So, Dr. Mathew Kurian is a prolific cataract surgeon, anterior segment surgeon. He is the medical superintendent and heading cataract services at Chaitanya Eye Institute in Palarivattam.
Thank you, Dr. Satish. I have financial interests in EMR company and in a portable OCT company, both working out of India. IFIS described first by Chan in 2005 and is documented in almost all majority of patients using tamsulosin, and in cataract surgery patients it's about 1%. So what it does is it reduces iris rigidity and dilator muscle function, and it's associated with hypertension, diabetes, and age. Alpha-1 adrenergic antagonists are the common culprits, and males with BPH treatment are considered to be the primary individuals at risk. But we have to remember that this is not the only group of patients. Female urinary tract symptoms can be relieved by same tamsulosin group of drugs. And alpha-1 adrenergic blockers are also used for hypertension, PTSD, Raynaud's phenomenon, and pheocytochromos. And so a huge number of other patients can be also using these things. Triad of symptoms is poor dilatation, iris billowing, iris prolapse. And iris prolapse is the one with severe. Moderate IFIS would be poor dilatation with progress. So there is an increased risk of complications, PCR being the most common, about 4% more than normal. Iris trauma is 22%. So these are the challenges that we witness during cataract surgery. The iris tends to follow any instrument going out of the eye, and often by the time you have completed the rhexis, you are aware that this is a floppy iris, and whether it is the main port or the side port, the iris tends to get entrapped even if the port is a small, narrow, long port. So progressive chafing can happen, and often once it gets caught in the phaco-tip, it has a tendency for it to find its way into the phaco-tip, and these strands are best amputated using a cutter. So this is the best way to get out of the problem, and all stages of surgery from rhexis, hydronucleus management, epinucleus, and cortex removal, all of them can be made worse by this. Here, IOL implantation, you can see the iris going out through the side port. Okay, and wound hydration also is challenging. Stopping tamsulosin is probably of no use. Even a single dose in the past is associated with this. So how do you know, are you going to have a problem with the IFIS situation in an individual taking tamsulosin? Preoperatively, I think the most important thing to do is the Steve Ashnov's suggestion of a pupil dilatation test, tropicamide, phenylephrine, wait for 20 minutes and look and see whether the pupil has dilated. If it's more than 6.5, you're most likely in safe territory. You need only pharmacological agents. If it's approximately 6, you are likely to have minor problems. Tight incisions and soft shell technique will take care of the problems. But if it is 5.5 millimeters, then expect to be in trouble. Have all your armamentarium ready. You're preparing the anterior chamber for IFIS. We have phenocaine that is available now, and that is a tremendous boost to the topical drops that we intracameral drops that we have. Use the soft shell technique, and a modification of the soft shell technique is to coat just the anterior capsule with a little bit of the phenocaine eye drops. So the iris is tamponaded with viscoat. The cohesive is used in the center, and the bridge is xylocaine phenocaine combination. And maintain this during your surgery. Use low parameters. Vacuum should be low. Everything should be much more gentle. So the mechanical devices are what is most important over here, and we need to be familiar and have them ready. iris hooks, what I prefer personally in these kind of situations, because it drags the iris away from the incision openings and brings it closer to the angle. Here, the iris is prolapsed through the main port, decompress, put viscoat, create space. The subincisional one should be under and pull the iris back, hook up the rest of the iris. Typically, I use square or maximum a pentagon. And once this is done, the stretch on the pupil ensures that it is no longer floppy. End of surgery, I leave the irrigation on using a one-handed technique. I release the stoppers on the iris hooks and slide the hook out of the incisions following the curvature of the hook without traumatizing the iris. And often this gives a reasonably good shape to the pupil at the end without too much of sphincter tears. So this is the pentagon, the previous one was the square. The Malugan ring is a device which I have used very few times because of cost reasons, and the distal hook is scroll is engaged. The intermediate two scrolls are also engaged by depressing it. The proximal scroll is finally engaged using a second instrument. Removing it is reverse of the thing, where the subincisional scroll is hooked back onto the injector and the rest of it comes out. Tendency for the distal iris to get occasionally trapped in the scrolls. Melogen came out with this slightly before the BHEX. So in the Western world, the Melogen ring is holding sway. But I think personally, the BHEX is a wonderful device. I use it with the microrhexis forceps. What I am doing is hold it, introduce it in, and put in the distal scroll with the flanges in under the iris. Then the right side one goes under the iris. I nudge the whole ring distally so that the subincisional scrolls come out. And there I am holding it and tucking the last flange underneath. And by using the microrhexis forceps, which is not what is recommended by Dr. Suvain, I find it easier to just proceed with the microrhexis forceps for completing the rhexis. I typically remove it through the side port, which is a 1.1 millimeter incision under irrigation. And because it's such a uniplanar device and thin device, it comes out pretty much easy through the side port. So in conclusion, considerable variation in sensitivity is seen, and we can determine that by the pre-op dilatation test, intracameral mydriatrics, soft shell technique, low flow phaco, and mechanical pupillary dilatation helps us to manage this complex situation. Thank you.
Thank you, Mathew.